Hi, I'm Peter. I'm a physiotherapist and this Institute Fellow based in Cambridge. I'm going to talk today about the results of our recently completed national survey regarding cardiorespiratory training after stroke. So cardiorespiratory training may have the potential to significantly reduce the risk of subsequent strokes. And by cardiorespiratory training, I mean exercise, sometimes referred to as aerobic training, in which the body's large muscle groups move in a rhythmic manner for a sustained period of time, such as walking, cycling, or running, but importantly, at an intensity sufficient to produce a cardiorespiratory training effect. That is, it will improve the fitness or health of the cardiorespiratory system. So strokes and transient ischemic attacks, or TIAs, sometimes referred to as mini strokes, have life-changing effects on individuals and their families. Strokes are the leading cause of long-term complex disability in the UK, and many people experience long-term cognitive, communicative, physical, and emotional impairments. The 5-year risk of a recurrent stroke after TIA or stroke is approximately 10%, and the 5-year risk of an acute coronary syndrome after an ischemic stroke is again about 10%. Relating to secondary prevention and mirroring international guidelines, the 2023 National Clinical Guidelines for Stroke for the UK and Ireland recommend that for people with stroke should be offered cardiorespiratory training or mixed training, regardless of age, time since having the stroke, and severity of impairment. And I think important context here is I believe there's general acceptance that secondary prevention management after stroke and TIA in the UK could be improved. That's especially true if we compare it to secondary prevention after a cardiac event, where most people will be offered, if not all people will be offered, and referred to cardiac rehabilitation, which is a well-evidenced, established secondary prevention program of exercise education and support for people with heart conditions. And people with a stroke face similar needs and health risks to those addressed by cardiac rehabilitation, but there's no current equivalent program that's routinely available for them across the UK. So to investigate the implementation of the guidelines and to investigate current practice, we surveyed physiotherapists and exercise professionals whose work includes working in stroke or cardiac rehabilitation services. And we included those working in cardiac rehabilitation services as we were aware of examples where people with stroke or TIA may be eligible for these services or may have accessed these services. And we assessed the current provision and beliefs regarding the challenges and risks of cardiorespiratory training after stroke. So we had 253 respondents to our survey, the majority of which worked in the NHS, were physiotherapists, worked in community or outpatient settings with an average of 15 years of experience. As you can see from the figure on the right, we had representation from all regions in the UK, although there was a bias towards the south and east of England. Of the 253 participants, 187 worked in stroke rehabilitation services, illustrated by the red circles on the left, and 66 worked in specialist services delivering cardiorespiratory training, such as cardiac rehabilitation, illustrated by the blue circles on the right. Focusing initially on those working in stroke rehabilitation services, of that 187, 60% reported that they incorporate cardiorespiratory training into routine stroke rehabilitation. A similar proportion, 61% of those working in specialist services delivering cardiorespiratory training, reported that they see people after stroke or TIA. So at first inspection of the data, this appears quite encouraging in that the majority of survey participants are delivering cardiorespiratory training to people after stroke or TIA. If we focus initially on the red circles representing those in stroke rehabilitation services and delve deeper, the picture's a little more nuanced, in that of those 60% incorporating cardiorespiratory training, only 38% report that they incorporate cardiorespiratory training with all their patients. And then looking at the blue group representing those working in specialist cardiorespiratory training services, of the 61% who reported that they see people after stroke or TIA, 74% of those people reported that people after stroke or TIA would only be eligible for their services if they had a secondary diagnosis, such as a cardiac condition. And so together, this would suggest that there is a significant group of patients who do not receive cardiorespiratory training after stroke or TIA. We also saw very large variation in how cardiorespiratory training was delivered and in the frequency and dose. And on average, most reported doses of cardiorespiratory training after stroke were below the guideline recommendations, suggesting further gaps in implementation of these guidelines. We asked those in stroke rehabilitation services who they were more likely to incorporate cardiorespiratory training with. Again, we saw large variations in responses, but 3 of the multiple choice options were selected by more than 50% of respondents, in that they agreed that they were more likely to incorporate cardiorespiratory training with people with minimal physical disability, minimal cognitive disability, and those who were more active before their stroke. And we also asked those working in the specialist cardiorespiratory training services about their eligibility criteria. And 50% reported criteria based on the severity of stroke impairments or the ability to walk or exercise independently. So from this, we infer that there is likely inequality in terms of who is receiving cardiorespiratory training, and that those with greater disability may be less likely to receive or be eligible for cardiorespiratory training. We asked both groups delivering cardiorespiratory training about what their concerns were with delivering cardiorespiratory training to this group. Again, we saw a large number of answers given, the most common of which were concerns around the risk of falling, fatigue, and the risk of negative effect on movement patterns being relearned after stroke. The proportion of respondents concerned with the risk of serious adverse events while exercising was significantly higher among those working in stroke rehabilitation services. We don't know why that was, but it might be that due to the acuity of patients seen, and that those working in stroke rehabilitation services typically saw patients much earlier after stroke or TIA than those in the specialist cardiorespiratory training services. We asked those not currently delivering cardiorespiratory training what factors were preventing them from delivering cardiorespiratory training to people after stroke and TIA. Both those working in stroke rehabilitation and in the specialist cardiorespiratory training services identified skills and knowledge as an important factor, either regarding cardiorespiratory training or regarding stroke. They identified resources, particularly around staffing and lack of guidelines. Those in specialist cardiorespiratory training services also highlighted that some of their services were not commissioned for stroke, and some, presumably where the services were commissioned, that people were just not referred to the service. Finally, we asked participants to please rate their confidence to deliver cardiorespiratory training to people with stroke or TIA, regardless of the level of impairment, from 1, not at all confident, to 5, fully confident. We can see from the graph there's quite a variation in confidence over that distribution, but those working in the specialist cardiorespiratory training services typically had higher confidence than those in the stroke rehabilitation services. But both groups of respondents commonly identified education and training and guidelines as factors that would improve their confidence. So in summary, there was large variation in whether and how cardiorespiratory training is being delivered, and our results would indicate that in many cases, the guidelines are not being currently implemented. People with greater disability may be less likely to receive cardiorespiratory training, and we believe this is a really important issue to address in terms of improving and reducing that inequality. Many factors may influence both the delivery of and confidence in cardiorespiratory training, including the need for education, training, and guidelines. So we're currently conducting interviews to add depth and more context to our survey findings. We have ongoing work with people who have lived experience of stroke and those that have lived experience of cardiorespiratory training after stroke. We're planning a workshop in 2026 to address the challenges and issues raised by the findings and inviting experts, including those successfully implementing the guidelines currently. And we're preparing a funding application to co-develop and test an inclusive secondary prevention programme for people after stroke and TIA. So I'd like to thank all our participants and organisations that helped with the dissemination of our survey. I'd like to thank the funders and the research team.